Go see my dog.
Good morning. You're listening to Retake Our Democracy, a 30-minute weekly show that airs at 8:30 a.m. each Saturday morning on KSFR 101.1 FM, your Santa Fe public radio station. And I'm Paul Gibson, the host of Retake Our Democracy. And today I'm speaking with Mary Feldblum, the Director of Health Security for New Mexicans campaign. We have lots to talk about, but first we have a few short announcements. Last week, I interviewed Representative Cristina Ortez, the rep from District 42, representing Taos in parts of Rio Arriba County. And the week prior, I spoke with Jeff Levine, a Taos-based activist who was co-founder of Renewable Taos and is the current chair of the Democratic Party of New Mexico's State Platform and Resolutions Committee. I can almost never get that out of my mouth. So January has been Taos month on Retake Radio, although that's getting broken up today. If you're driving around and miss any of this show, you can watch the full YouTube recording of this and any prior interview by going to retakeourdemocracy.org and clicking on the Retake on the Radio button on the right side of the homepage. You can find links to the recordings of all of our prior shows there. I want to acknowledge that we are conducting this show on stolen Tewa land and to thank our Tewa neighbors for being such good stewards of the land. May we do half as well as they do. I also want to remind you that the 2022 legislative session is underway and Retake is operating our legislative alert system this year and our weekly huddles as well. We send out alerts whenever one of our bills we support or oppose is scheduled to be heard in committee on the chamber floor. Each alert includes a summary of the bill, speaking points, and legislator contact information, as well as information how you can watch the hearings and offer comments on bills from your couch, making it much easier for you to effectively raise your voice. You don't have to come to the roundhouse and expose yourself to COVID. This is year 5 of the alert system, so we've got the hang of it. You can sign up for the alerts by going to our homepage at retakeourdemocracy.org and look for the red letters and get alerts button on the right side of the homepage. In addition to our alert system, we offer a weekly Zoom huddle. We began doing our huddles last year and they are backed by popular demand. They occur every Wednesday evening from 6 to 7, and the huddles almost always include 1 or 2 legislators and most often representatives from ally organizations who are advancing bills we support. During the huddles, we discuss what transpired in the prior week and we preview what is coming in the following week. Of most importance, we discuss what we heard in hearings. Most importantly, we discuss the concerns raised by opponents of our bills. In this way, we can hone our messaging about the bills with info that counters or responds to the concerns raised. To register for our Zoom huddle, just go to retakeourdemocracy.org and click on the New Mexico legislation in the menu bar. A link to register for the next huddle will be near the top of the page. Enough announcements. Let's get started. Welcome, Mary.
Welcome. I'm so glad you're doing better after that scare.
Yeah, well, thank you. You know, I'm done with scares.
I can imagine.
I always like to let our guests introduce themselves. So now that we, can you tell us a little bit about how you got into health security and health policy advocacy?
Very quickly, because there's a lot to cover, I know. I'm a PhD. I was an academic, got involved in policy and state lobbying in the late 1980s. My God, it's a century ago. And worked for Consumers Union. I was directing the New Mexico Healthcare Project. And that's where in 1992, I got involved in developing a plan with a coalition that would automatically insure most New Mexicans and freedom of choice of doctor. And that plan is developed over the years with the largest coalition in the history of the state, and I'm the executive director.
Great. So can you tell us exactly what the Health Security Act is?
The act itself would enable our state to create its own health plan that automatically covers most New Mexicans. The military, for instance, would have their own plans. The tribes and sovereign nations could voluntarily join. We think they will, but there are a lot of complexities that they have to be assured. But most New Mexicans would have automatic coverage, freedom of choice of doctor and hospital, even across state lines, no more networks, and services that could be no less than what the state employees have, which is a really good package of services, includes mental health, acupuncture. There are several studies that have been conducted, three, in fact, that all say that if we self-insure, basically, put almost everybody in one health plan, the state is going to see much lower healthcare costs, lower in the sense of the rate of increase will be lower, not that health costs will go down. What's really critical is that this bill will be, the plan would be administered by a citizens board like a co-op and geographically representative. And the members of the board must be recipients of the plan. And 10 represent consumer and business interests, 5 represent health facility provider interests. No insurance people are on this board. And its meetings are open to the public. Our premiums would go into this plan, just like a co-op, instead of to the insurance industry. And what that means is billions of dollars can be invested with even 1% interest, which will provide a reserve fund and also a lot of money so that we can really invest in our needed rural and underserved areas.
Can you tell us, I know one of the things involved is helping rural hospitals. Can you talk just a little bit about that?
Absolutely. There are several provisions that would help rural hospitals. And one is, and is also rural healthcare providers, there's a provision in the act itself that higher reimbursement rates can be designated for rural and underserved areas. But the big thing about rural hospitals, and so many of them are in financial trouble, is that the bill, and this was Representative Max Call that put it in 1993, requires what's called global budgets. And global budgets is what's used in Europe and Canada and Japan. Essentially, hospitals get negotiated budgets for operating costs. They do not send their patients who are in the hospitals pages and pages of detailed charges. So what's great about a global budget is it guarantees a hospital a revenue stream. And what's exciting is that in the United States, several years ago, the Center for Medicare and Medicaid, the Innovation Center for Center and Medicaid Services, offers money, funds for a state that wants to do this. Maryland had started it maybe 4 or 5 years ago with great success. Pennsylvania is doing it only for their rural hospitals, and we'll see what that happens, but it should be an enormous blessing. And you'll find it's required in the Health Security Act and in the design process, which is going on of the Health Security Plan, which is created by the Act. And so the idea is to have our hospitals, and I think clinics also, work together to figure out how such a system would work in our state and get the federal dollars so we could set it up.
Okay. So I'm guessing I heard you say that with global budgeting there would only be doctors wouldn't be submitting pages and pages of coding saying what services they delivered.
No, hospitals.
Hospitals wouldn't.
Yeah.
Okay.
There's another issue with provider payment systems and
Right.
simplifying coding.
Can you talk about that for a second? Because I don't know if you know, our daughter is in her last year of med school at UC Davis.
Oh.
And she was about ready to quit over all in her first rotation. She was just overwhelmed, internal medicine, all the coding she had to do. She said she spent more time on the computer than with patients. And
Yes.
That's why she's going into the ER as her residency, because there's not nearly as much paperwork there. Can you talk a little bit about the burden that is placed on doctors and doctors' offices for producing?
Oh, we held a Zoom panel, our campaign, on December 11th. And if people want to access it, you can go to our website, which is www.nmhealthsecurity.org. There are 5 health professionals there representing the pharmacists, family practice, a specialist, psychologist, and one other nurse practitioner, because some of them are private. and no one from Albuquerque, by the way. So it was a really interesting panel. They were asked what procedures do they have to comply with in order to be paid, and which interfere with patient care. And the list was tremendous and across
Mhm.
the board. It's not only the coding system. We are the most complex system in the world, and it adds such a heavy price tag to our costs, that it's enormous. And the Mayo Clinic has some surveys that confirm what your daughter is experiencing, that too many health professionals spend twice as much time work dealing with computers and paperwork than they do with their patients.
Uh,
And so there are so many fixes that need to be made. Pre-authorization is another one. There's a whole list that we put on our website based on that very interesting panel. And the IT system. You can go to Loveless Hospital and you're a Presbyterian patient and you're unconscious. They don't know what your history is
right.
because it's proprietary. You don't have a card. In France, you go to a doctor, he'll know everything about you, what you're allergic to, what your history has been. That doesn't happen in the United States. So what we need is what's called an interoperational IT system. And so that there are lots of very important fixes for providers in Europe and Japan and Canada. They use what's called an all-payer payment system. We have a payment system. You go to the doctor for a general checkup, and he probably has 20, 25 different rates depending on the insurance plan. And then
Wow.
he may have some collection that has to happen. And it's just, and negotiating those rates. It is just such an extraordinarily complex system.
So given how hard it seems to be for the feds in the US to make even most modest healthcare reforms, could a successful implementation in New Mexico break gridlock in Washington? And what I'm thinking of here is in Canada, I believe, where Saskatchewan led the way for healthcare reform, and they implemented something like our Health Security Act. And within a couple, 3 years, the whole country was looking at Saskatchewan and the results they were achieving, and it became their national model. Can you talk a little bit about that?
Saskatchewan still is the poorest province in Canada. And after World War II, they wanted to begin to create a universal coverage plan for their provincial residents. And what is important to know is that it took them quite a few years to design it. They actually had a design commission to figure this out.
Sounds like something you're thinking about.
What we have got, yeah. And when they finally figured it out, it just took hold, and other provinces began to follow suit with their own design. And eventually the Canadian government passed its national plan.
Okay, so let's talk a little bit about what happened in 2021 session to advance the Health Security Act to where it is today. I
Well,
remember it being quite a process.
it's very exciting. Our sponsors, Representative Debbie Armstrong and Senator Ortiz Pino, decided to, after the KNG study was produced,
Mhm.
and these studies have to do projections. The assumption KNG made was that the plan would begin in 2024, but you really don't know what federal dollars would look like. You don't know exactly what hospital revenues will look like. So they're making projections. So both our sponsors said, let's reverse the process. Let's start the design process of this so that when we're ready, when the design is completed, we'll be able to do a cost analysis of the plan as designed. No more projections. So in 2021, it was very exciting process where we got quite a bit of funds, and the superintendent of insurance was selected to oversee the process, and which makes sense because this is an insurance plan. And So that's was very exciting. We're the first state in the United States to actually begin to roll up our sleeves to answer the detailed questions that Saskatchewan had to do before it was up and running. And how is this going to work? How is enrollment going to take place? How are providers going to be paid? How's the global budgeting system going to work? We need a bulk purchasing of drugs system. So all of that is going to be explored and answered in the decision-making process, which is going to be multi-year. This is complicated, and our campaign really feels strongly that it has to be transparent, and all of us will have a say and input into what's going on.
Okay, we got to take a short break here to remind our listeners that KSFR is more important than ever now with the age of misinformation. KSFR offers timely news alerts and a wide range of programming to keep you sane in these challenging times. So for those of you who can afford it, please consider making a contribution and think of it as your ticket for admission to a wealth of welcome programming. Just go to ksfr.org and click on the donate button. Let's get back to our discussion with Mary Feldblum. So in 2021, you mentioned briefly that, we raised a lot of money. Can you tell us a little bit about how that process went with accessing junior bill money?
Oh, we contacted as soon as we knew about the junior money was available. It hasn't been available for a while. And for your listeners that may not know what junior is, the legislature has a budget that they have to approve for the state. And that the House Appropriations and Senate Finance are the ones that work with that. Then if there's a surplus, in the past, we haven't really had surpluses, there've been lots of cuts. If there is a surplus, there are two ways to spend that surplus. Is allow those committees to decide how it's spent, or divide that surplus up so that each legislator gets a little piece of the pie and can decide how they want to spend their dollars that are allocated to them. So that's what junior is. Junior, and because of the surplus this year, there's a sizable junior pot. Each senator gets $600,000 to decide, and each House member now gets $360,000, I think. And so what we had to do and what we've done this year is talk and alert different legislators that we know are sympathetic, and ask them if they could allocate, because you have to do it $50,000 sums, at least 50,000 to this, to continuing what we call the design process. And so that's, we were very prepared this year. So with our sponsors, we had language, because you have to have very specific language, and you don't want to tie it to a bill, because if your bill doesn't pass, then you lose your money.
And we were on the phone quite a bit on Saturday and Sunday.
Yes,
And
and you
how
were
did we
helpful
do?
last time.
What was that?
You were so helpful last time. But
Oh.
in addition to the junior monies, the Legislative Health and Human Services Committee, which is the permanent committee that meets after the session, it endorsed a bill to continue this design process. There were 4 research topics done this past year. The superintendent has done a great job of hiring wonderful consultants to deal with provider payment systems, global budgets, how are they working in Europe, for instance, as well as, to better understand the rules in the United States. Let's find out what waivers and agreements we need. So there are 4 research topics, and this afternoon before Senate Health and Public Affairs Committee, the superintendent.
We should mention that we're recording this on Wednesday. And so when she says this afternoon, she's talking about Wednesday prior, because this airs on Saturday.
So you can listen to it through the archives. Because it'll be recorded, but he's making that presentation. But so that's that bill is requesting $1.6 million. That will likely pass. This first committee, and then it goes to Senate Finance, and it sits there because it's not a junior, it's a supplement. And one advantage in knowing the junior monies is we'll have some idea as to what percentage of that 1.5 million is is going to go through junior. We've gotten some questions from some of our wonderful supporters, and it's a very good question: is why that amount of money? You know, what is that? What is that going to go for? And the hiring consultants, for instance, just to who can explore a really good interoperational IT system, or reducing coding for providers, are complex subjects, and we need to get all the information we can get. I mean, I'd be curious to know how France does it. You know, it's so simple in France.
Right.
And can we in New Mexico do that? And then you need legal advice, what legally you can do, what legally you can't. What you need economists that are going to look at, if you have a bulk purchasing of drugs, I plan A or B or C, what is the impact? You know, what's the cost? And maybe the one that's the most costly is the one that's most effective. So you need some kind of economic analysis as well. So you need excellent researchers who have and expertise, and probably not just one researcher or consultant for one area. You may want to have a variety of them. And you know, so bulk purchasing of drugs, continuing the global budget exploration. There's no reason why we shouldn't start applying for those federal dollars now. Working with different providers about the payment system, which is so complicated in the United States, and exploring what is called in Europe an all-payer payment system. And you can find out more about that on our website. But you know, there's a lot of research, and you know, we want to address the big problems as best we can. This is the beginning of that process of seeing what's out there. So once we understand the different framework, different possibilities, their legal and economic ramifications, we can begin to make decisions about what would work in our state. So it's smothered in green and red chili. It's that's why it's quite a bit of money. If we don't get the 1.5 million, we'll be reducing the number of consultants. That's probably what it is.
And after all, you're planning a health system for millions of New Mexicans, and it's $1 billion system probably by the time you add everything up.
Oh, 8 billion.
$8 billion system. So, you know, what's $1 million to get it right? The last thing we need to do is get this off the ground and have it blow up, right?
Well, yeah, that's true. And what is really important for people to understand is that we need to look at the entire system. Climate change is one that you have to look at the entire system. We use energy for so many things, including the Zoom, and in our lives, and your refrigerators and your cars. I mean, you start thinking about your iPhone. And so if you're talking about reducing reliance on fossil fuels, you're really talking about a very integrated plan that has to happen. And it's the same thing with healthcare. In healthcare, you cannot just work on one little piece and not have it have consequences to others, other pieces. And so what this does, this design process does, is it allows New Mexico to look at the whole picture and to figure out how to integrate the system. And that's what the health security plan would do. The act itself gives guidance. It doesn't answer lots of questions. It raises a lot of issues that need to be answered. And that's important. And that's what this process is about. And sure, you're right. You have to do it very carefully. And I think all of us need to feel comfortable that this is the way to go. We'll be excited so that by the time we get our card and go to the doctor of our choice, that physician is paid in a timely fashion. And then the other issue is how our premiums are going to be invested. It's going to go to this co-op. And we're talking billions of dollars, which will have a reserve fund, but also can invest in needed services and in rural and underserved areas. But how is that going to be invested? And that's an issue that's going to have to be discussed. How is enrollment going to take place? The plan isn't going to be perfect. If we have a problem, what is our appeals process like? What are our rights? What is a physician's rights? What is a nurse practitioner's rights? So, there's a lot of pieces. What kind of checks and balances are there? So we can be assured that there isn't a monkey business going on. And the attorney general, the state auditor, all of that. It's, we want to do it right in our state, and we could be a model. We really could.
So what more do you have to do in this session?
Well, essentially, we're asking for money via junior and via a little supplement from House Bill 2 to have the superintendent of insurance continue this design process.
And SB 80, correct?
SB 80 is the big number,
Right.
but it doesn't include the junior money, so that could be subtracted from that total. So we are pushing for the funds to continue this process. That's basically what we're doing. And the superintendent of insurance will work carefully with the sponsors and us. And we are a huge coalition. We work very closely with many provider organizations and many local groups, councils, the Public Health Association, and others. And we've got a lot of wonderful resources available in our state to help design something. And the read I'm getting is people are getting excited about this because we have a chance to really do something that is going to really bring back the word care in healthcare.
Wouldn't it be nice for New Mexico to be leading the way in something positive instead of leading the way in emissions and stuff?
We have a real chance.
Well, thank you. So when the study and design process is completed, what will we know, and when do you anticipate that the study would be completed?
I wouldn't call it a study. I would call it, because I think it's rolling up your sleeves and designing it, right?
Okay. Apologies.
The estimate this year will really hopefully expand the possibilities, the research we need to make decisions. We're hoping in 2023 that commission that I talked about, the Health Security Commission, will be passed and approved by the legislature, and they will finish the design process. But we need to take our time, and then immediately we could design a bulk purchasing of drugs program and global budgets.
Okay, well, we're out of time for the radio show, Mary. Can you tell people where they can get more information? Give them the website.
Yes, on our website, it's www.nmhealthsecurity.org, and you can sign up to be on our alert system as well. But you'll get a lot of information on the website.
So for those of you watching on YouTube, we'll be back in just a second, but we have to sign off for the radio show now. We'll be back next week. My crystal ball doesn't tell me who my guest will be, but we'll be back. So thank you very much. Stay safe, healthy, and active. It's the only way we fix this mess.
Thank you.
Thank you. Okay, we had to do a little pause so that the engineers at KSFR knew when we were done with the radio show. So now we're back by miracle of podcast with Mary Feldblum. We're going to continue the discussion. I was frantically signaling her that we needed to cut short, and I ran a little bit over, but I don't think KSFR will be too mad. But now we can relax and have a conversation. So the hope isn't to really your expectation isn't that by the 2023 session, we'll have a bill to present for a full plan. Is that correct?
Not the full plan, just create the commission, because the superintendent doesn't have an advisory committee, right? And I would say, think of this process as like the architects. And when the commission is set up, they're like the builders. They're the ones that are really, they may tell the architect what you're thinking here won't work, because they're responsible. The commission is going to be responsible for administering the plan. So it makes a lot of sense to have this commission finish the design process. And what's good is that with all the research done this coming year, the legislature will have some idea about how valuable this is. And what interim measures that will lead to health security, like bulk purchasing of drugs, can be established now. We don't want our system to fall apart now. So there are lots of things that we can do that will actually help with the design of health security.
Okay, so basically in 2023, we're looking for the creation of a commission who will then tease out a lot more of take some
Right.
of the research that you've done and that the design process has done so far and directly apply it to how it will roll out in New Mexico. And so
Right.
by 2024, maybe 2025, we would be able to seek authorization to establish the system.
And at that time, a cost analysis can be done of the plan as designed, right?
Okay,
And we will know exactly what federal dollars are available, because you're gonna, there is, how are we gonna pay for the plan? So once you know the cost, you subtract public dollars from that cost, because those are coming in. And then the remainder will be made up with a system of premiums based on your income, a minimum below which people wouldn't pay, and a cap on the high end, and employer contributions based on size as well as payroll. And there'll be formulas, and the legislature will have a package to approve and say, this is a go. Mhm.
okay, well, may it be so, Mary. You've worked so hard on this, and along with a lot of your allies, we're certainly hoping that one of the payoffs is a health security for New Mexico system in 2025. Let's circle back to the junior money process. I don't know how many legislators, I don't know many legislators who actually like it, and quite a few find it undemocratic. What is the junior? You mentioned a little bit about what it is, and it's tied to the surplus. And so it only occurs in surplus years, which we've had the last two. What was the original intent of the process, and how is the process undemocratic, or is it from your
Well,
perspective?
I think that it raises a lot of questions. I mean, right now, if you didn't have junior, the surplus would be decided by the chairs of Senate Finance and House Appropriations.
Enough
So then
said.
you hear from those legislators that are upset with the junior, they're also upset with the secretive process behind closed doors of how decisions are made. And this is not just these, it's been done for years this way,
Right,
about those decisions. So you're kind of breaking it up, if you can, you're saying, okay, the behind the closed doors supplements will continue, but you as a legislator can have a little piece of the pie. It's very, so, I mean, looking at House appropriations and the budget and Senate finance, it's good to look at that, of how we're determining the budget and these things, and the role of the legislative finance staff, particularly the executive director, who has a lot of power in those decisions. But I mean, that's a good question. But at this point, if any legislator threw away and said, "Oh, I'm not doing it," that would be they're hurting some programs. They really are. And that is the system. So why would you throw it? What essentially you would be doing is giving it to the chairs of finance and appropriations to
right,
spend that money.
right. And in the larger scheme, we're talking about an $8 billion budget. I did some rough calculations. It looks like it's about 25 million for the Senate and 25 million for the House reps. So that's about $50 million, 25 and 25.
Mhm.
Pretty good at that math. And so, that's a fraction of the state budget, a very small fraction. And let's face it, if it weren't for junior money, we wouldn't be talking about how the Health Security Act study is going right now, because it wouldn't
Well, we
be.
wouldn't have had it last session. We wouldn't have
Right,
even done
right,
without the junior money. And what's wonderful is it shows us which legislators are really interested, and some of them have already tapped out their funds for good causes. But boy, we're getting, we really got an enormous number of legislators in support of this process, which is very heartening. We have more and more legislators. We really do have the votes on the floor of the House and the Senate to pass something like this when it gets to the floor, but I think Representative Armstrong and Ortiz y Pino were right on target by saying, let's give them more details and let's involve providers and different groups of rural New Mexicans, and to feel like, wow, we're really learning things, and we'll be making some interesting decisions about how we provide healthcare in our state. So I think that process, that's never been done. It's always been particular programs,
Right.
that are very important, but really aren't looking at the system. And there's no question that this is a systemic problem. We have to design a systemic solution where you have a state with a small population, and setting up our own health plan makes a lot of economic sense. We already have 3 studies that indicated that. And the question is how you do that and who is in. I mean, Saskatchewan had a very different challenge post-World War II. France did post-World War II than we did, what we do today. And so how is Medicaid going to be included in this? How can Medicare, because Medicare is very complicated, and there are Medicare recipients that have supplements, and the Health Security Act has protections for Medicare recipients so that they won't lose anything as long as their employer gives it to them, or Congress with Medicare. I mean, that the plan can't control, but we want protections. But I think that people need to understand is there is a difference between the act, which was not passed, no, it's not law, which gives guidelines, and the design process, which stimulates what's being designed, like global budgets is in the act. So we need to, it's very important to use with global budgets. The act doesn't say the method at which a provider would be paid. There are a lot of methods being used in the United States, like fee-for-service, value-based payment options, which are essentially risk-based. So you give a group of physicians a capitated rate, and if they go over, they get higher risk patients, let's say, and they go over that the total budget that the capitated rate would collect for their practice, it's their risk. They have to eat up the problem. And so we have very risk-based approaches and solutions, and we all need to learn about them. That's what the purpose of the research is, to understand that, and to understand an all-payer payment system. We have a great briefing paper on what that is, because even many providers didn't know what it was. And so it tells you what it is, and it's done differently in Germany and in Japan and elsewhere. But so there are basic questions. And part of it, and the access this, is that health professionals would be negotiating how they're paid. And we have antitrust laws in the United States. So how is that going to work? Who's going to negotiate, right? Then France is different from Germany. So, there are questions that we're going to have to get providers thinking about how they would want that negotiation process to take place, and the appeals process if they didn't like it.
Okay, that's going to be an exciting thing. I just want to tell our listeners, Retake is very involved, as you all know, in the legislative process. And one of the highlights of every session is working with Mary, because the end product, the end outcome is something that will impact the state for generations. And I can't tell you how exciting it is, the prospect. I think we're going to get this done, Mary.
Well, it's going to attract, I think it's going to attract providers to our state.
You might even get our daughter to move to New Mexico.
Yeah, well, that would be great. But, I have a friend who's the head of gerontology department at a big hospital in New York City. And he finally read the bill and he said, I'm moving to New Mexico. And as somebody into gerontology, I said, great, we need you. But, the idea that you'd simplify life. And then, the state spends a lot of money on healthcare. It's not just Medicaid. It's retirees, teachers, state employees. They also spend it on workers' compensation insurance, because there's health there. And they also have cars. And so, the state is going to see reductions in healthcare. So that means that they can invest. And businesses want predictability. If
Right.
they can have more predictable costs, that's going to be very attractive. And small businesses tell me they get frustrated if they don't offer healthcare. They end up being training grounds for that great salesperson who then moves on to a company that does provide those benefits.
Mhm.
So that's going to mean that, a lot of people would like to work for small business. And this will give them a greater supply to select, good people for and retain them. And nobody will ever have to worry about going bankrupt over healthcare. I mean, what a terrible thing to have to experience if you are sick or a loved one is sick and
I
you're
can't
worried about
imagine. That's one
that.
thing.
That is unconscionable, and it's European friends of mine, people in Europe and to Canada and in Japan are just in shock. We're a wealthy nation and people are scared to death. In Canada, I understand there are people that if they come to the United States, they get travel insurance because they're scared to death of getting socked with a bill.
I can imagine. So thank you very, very much, Mary, for being with us. And I hope to see you again this evening, being Wednesday, not Saturday, at Retakes Huddle. And we'll be in the trenches there pulling for you and calling and sending emails to get support for your HB 80, SB 80. And
That's this afternoon.
I
So
know,
yeah, tonight would be too late.
right, Wednesday.
Mhm,
I'm going to be on as soon as we get off this call. I'll be getting ready.
mhm.
So thank
That's
you
great.
very much, Mary.
Thank you so much, Paul, and for all the great work that you do and all your listeners do, because it really makes a difference. I can tell you, as somebody who's lobbied for many years, and I know we all feel discouraged with our powerlessness. We're not. We
Okay.
can make a difference.
All right. Well, we'll see if we feel that way after the hydrogen hub hearing today. Tomorrow, Thursday. All right. Thank you very much, Mary. We'll talk soon.
Take care. Take care.